Nobody better than Dr. Kevin Most, Senior Vice President, Medical Affairs, Chief Medical Officer, Northwestern Medicine, Central DuPage Hospital. I've said it a million times, Jane. I've said it a million times, Nick. I plan on getting really sick. I go straight to Central DuPage Hospital. I just collapse in the parking lot, even if I'm feeling fine, because I know I'm going to get great care there. That's the kind of faith I have.
I want you to collapse in the parking lot and fake it.
Well, it's not a fake thing. I'm just pre-sick.
Oh, pre-sick.
Right. But we're really glad that you tape your insurance card and your copay to your shirt.
Yes. It does help. It really does.
Pins it on his shirt.
Dr. Most, good morning. Thank you, as always, for doing this. 312-591-8900. We'll try to get a couple of texter questions in as we roll along here. The COVID vaccine annual shot now available. Am I wrong to call it an annual shot?
No, not at all. It certainly will be an annual shot because we know that the COVID virus has continued to mutate, and every time we get a variant, it's going to be just like influenza. But it'll be very interesting, Steve, I think, to see how many people get this shot and how apathetic are we now to vaccines at this point.
It's just, and I'm not going to beat a dead horse with COVID here, but it's an absolute medical miracle that this vaccine was developed in the time it was developed. It's impossible to quantify the exact number of lives that were saved. But it's just a flat-out miracle. And, I know there's a segment of people who are never going to believe in vaccines. The same year ago, the flu vaccine makes me sick. Look, science has gone through this race a million times. You're wrong. You're just wrong. You can believe how you want to believe. You're just wrong. But the fact is, this is a miracle that we've had this, but we now have to accept that we're living with it.
Yeah, and your parents always said, there's some people you can argue with and not argue, but you have a discussion with and you can sway, and there's others you can't. And if the ones you can't, then save your breath. So certainly when we look at the initial vaccine, how many lives it saved. But I think what people are saying now is, I had COVID. It wasn't that bad. Do I really want a shot? Mm-hmm. I've had it twice now. And we've been very fortunate that as the new strains have come out, they've become a little less virulent. So they're not causing the severe hospitalizations and deaths. They're causing illnesses like influenza.
So the original vaccine that Steve mentioned was a miracle that they did it in the amount of time they did it. Now we've had all these years to change up this vaccine because I feel like people think, that was too fast. There wasn't any testing done. But now how is that, I guess, the formula changed? I mean, every year we get a new flu shot, and we've been doing that for decades. How has this changed over the last years? Is it more carefully created? Are they looking at the old vaccine and changing it to match?
Yeah, Jane, you hit it right on the head. When we look at influenza, and for flu vaccine, if we got a 40, 50% effective rate, we were pretty happy because what we were doing is we were taking data from the southern hemisphere and making our decision in February and March as to what we're going to put into that vaccine. And you have to remember the flu vaccine protects you against 3 different strains, knowing that we couldn't predict which one was going to be the predominant strain. With COVID, it's a little bit different now because how quickly we can make the vaccine. We waited, till May to say, okay, what's the predominant strain here? And that's what we use. So now we're seeing a much more accurate vaccine, which hopefully they will do with influenza as well. Because, whether you know it or not, influenza still causes, 50,000 deaths a year, over hundreds of thousands of hospitalizations. So really we're looking at the technology of what we learned during COVID to make more accurate and to make more decisions as close to the time we need them before we decide which strain we're going to vaccinate against.
And we will get a Slurpee at some point, right? We'll get the blizzard of vaccines where it'll all be mixed into one.
Yeah, I would expect that next year, they're probably working on it right now, that you're just going to get one vaccine. Now, that'll be really interesting, too, to see how that affects people, because some people now are saying, you know what, I trust the flu vaccine. I'm still going to go get that. But they're still kind of hesitant now about the COVID vaccine because there's been so many kind of missteps in communication along the way. But certainly we're looking at COVID cases going up. It's not unusual for any of you to talk to friends and say, oh, yeah, I just had it. And we really don't have a good grasp on how many cases because it's not mandatory reporting right now. People are doing home tests. They're not seeking health care. And we're not really sure how many cases are out there right now.
And I feel like people don't even want to say, I had COVID. I just talked to somebody yesterday. Last week, he said, I'm very sick. I've been very sick.
Why wouldn't you want to see it?
Well, and then yesterday, I said, what did you have? Because he had some underlying conditions. He's like, I had COVID. Like, why didn't you tell me last week you had COVID?
Last thing about vaccines for the moment, anyway, is if you just go, no, vaccines are BS. It's all BS. Ask your grandparents about polio. And just do a little history work and Google up a few things of vaccines have changed the world and saved the world over, including what goes on in Africa every day.
Oh.
Many feel that their natural immunity is going to take care of this. Previous vaccinations can build up in your system and take care of this. How much truth? Any?
Well, as the strains come out with variants, your chance of protecting yourself decreases a little bit. Now, anybody who's had an infection since May, June, you still have very good immunity because you actually got the most common strain that's circulating right now. So anybody's like, well, you know what? I still want to get vaccinated, but I just had COVID, 2 weeks ago. I tell people you have 3 months of good natural immunity that we know. It'll wane after that. So you can wait a couple months before you get the vaccine. But, others are still going to be saying, hey, I've had COVID 3 times. I've gone through it. I've lived through it, and I'm not going to get the vaccine. I still tell people, you know what? Come down to the long COVID clinics that we're having at Northwestern to see the patients who have those long withstanding symptoms that we really haven't got our arms around yet of how to treat.
The COVID and flu shots, you can get them together. Same arm?
It's interesting. Everyone's saying, probably shouldn't do it in the same arm. A study just came out of Germany that showed, you should get them in the same arm, that the actual immunity goes up pretty dramatically by getting them both in the same arm. So a lot of people are still going to say, no, get them in separate arms. I was a separate arm guy, and now I read this study. I'm like, well, now I got to rethink this. But very interesting study that showed that, getting them in the same arm, you actually get a better response.
And we saw a story this week that kids do pretty well with this COVID strain that's out, yeah?
Yeah, they do. And when we start to look at that, we're looking at, all right, we have to look at this illness as a bigger picture. Certainly the kids will do well. The kids come home and get their parents sick. The parents aren't going to work. So we have to look at this almost like influenza. Kids do okay with influenza, but as it spreads, now it starts to impact the workforce. And I'm not saying take vaccines to make sure that you can stay at work, but certainly they're also going to come home and see grandma and grandpa sometimes, or they're also going to travel and see friends and relatives who may have underlying medical conditions that they don't know about. We should do this from a society's point of view to protect those who are around us, who don't have good immunity, and then also to slow the spread of any illness.
There is a texter question, which I think is a good one. I don't feel like I've ever had COVID. It would be good to know if I did. Is there a way to figure that out? Or maybe I don't want to know.
Well, you remember when it first started, we were doing just some blood tests on people for COVID antibodies. And we really have stopped doing those. And there's many reasons. This person who doesn't think they have, there's probably a good chance that they have. We figure somewhere between 97, 98%. The individual who hasn't had COVID should be playing the lottery because by this time, everyone's had it at least once, if not 2 or 3 times. Do they really need to know? No, it doesn't make a difference. The only difference I would say is if you're on the fence that you've never had COVID, then I would get vaccinated because you have no immunity if you haven't had COVID or gotten a vaccine.
If you're going to be out of the country at the end of October or early November, asking for a friend, should you get COVID and the flu vaccines before you go?
Yeah, I would. Certainly, international travel is one thing. Local travel, you have a lot more, flexibility, I'd say. An outbreak comes, hey, I'm going to get home. If you're traveling internationally, I can't tell you what the vaccination rates are now. In England, they started vaccinating COVID about 2.5 weeks ago, so again, well before us because they had a big outbreak. So certainly you're going to see vaccination rates that are unpredictable there, but as they're unpredictable here. But still, I would say, that flight as well as being in crowded airports and going to a place you don't want to get sick. You want to be as healthy as you can while you're on vacation. I wouldn't want to get the flu while I just paid thousands of dollars to go to Italy.
Well, it wasn't me. I was asking for a friend.
Yeah.
I've fallen and I can't get up. My cold medicine, does it work or is it nonsense? High blood pressure. We got a lot more to talk about with Dr. Kevin Most. Stand by for that. Before we get to that, we get to this. We interrupt this health segment for this health segment. Dr. Kevin Most, we got a problem here on this show. The legendary award-winning news hound, Nick Gale, has an abscessed tooth.
This is serious.
And he's been taking Advil like chiclets. And I think he's going to be, give me a more current reference in chiclets.
I like chiclets. That's good.
Tic Tacs. Yeah, like Tic Tacs. He's taken 4 an hour for the last 3 days.
3 days since Thursday.
And, I'm thinking he's going to get an ulcer along with his abscess tooth. All right, Dr. Most, you're a witness.
Well, I certainly hope you're not saying every hour.
No, every 4 hours, Doc.
Oh, okay.
4, what are these? 200 milligrams.
Yeah, 800 milligrams every 4 hours.
800, you are pushing it right there. You know, you're at the max dose. You're at the old prescription dose for max. So I would certainly be really kind of careful. Are you taking Tylenol or anything as well?
Yeah, I'll pop a couple Tylenol in there as well.
Like after the 4 hours or in between?
Yeah, like in between.
Yeah, and that's okay. Those are two totally different medications. So, the Advil is good anti-inflammatory as well as a pain reliever, and Tylenol is a pain reliever. And certainly if you have an abscess, it'll keep any fever down that you have there, but certainly hopefully get the abscess taken care of. But I would be really, really careful continuing that dose for any length of time. And are you taking the tablets or are you taking the gel caps?
No, tablets.
Yeah, I would consider going to the gel caps. So it's interesting to say, well, what's the big difference? So if you think of a pill as it sits on your stomach, it's going to sit there and start to disintegrate, right? But it's going to stay in one area. What happens with the gel caps, and that's why they work faster, is that gelatin capsule, as soon as it's gone and dissolves, that medication is a liquid and goes over a larger area of space. So the chance of it causing to sit in one area and cause a major ulcer problem decreases just because of the formulation of the medication.
And Doc knows something about this because he found out he was allergic to aspirin by having that sit in his stomach and almost killed him.
Doing the exact same thing, yep.
Yeah. So,
But my concern, though, for Nick is it's been 72 hours more than 72 hours, taking every 4 hours.
Yeah, that's what I'm saying. You're at a max dose, and really, I would be.
Well, other than trying to find my buddy on the street to sell me some fentanyl, what else can I? What else can I do?
Well, you take a ball peen hammer and you hit yourself in the toe, and you stop worrying about your tooth.
Yeah, right. No, I mean there's other pain medications that are out there that if hopefully your dentist understands what's going on, and he will get you on something that works better than Advil and actually is probably safer when you're looking at the dosing.
All right, Dr. Most, we hope Nick will live through the end of the week, but if not, we'll let you know who's here next week.
Yep.
Nice knowing you, Doc.
Phenylephrine, this is a new study that said the cold meds we take, the OTC cold meds we take for symptoms, Sudafed, Tylenol, cold flu, NyQuil, cold flu, all of them, that it's essentially, a placebo. Your thoughts?
Yeah, it's interesting. So in 2006, we took Sudafed, if everybody remembers the old Sudafed. We took Sudafed and stopped it. We didn't stop it from making it over the counter. It's still over the counter, but you have to go to the pharmacist, and they track and log how much you buy. And the reason for that is Sudafed was being used to make methamphetamine. So once we took that one out, they said, okay, what are we going to replace it with? There was a big scramble. They said, we're going to put in phenylephrine. Phenylephrine is a great decongestant in the nasal spray, therefore it'll be great in oral form. Well, as soon as we did that, way back in 2007, a lot of studies came out and said, hey, this really doesn't work because by the time it's absorbed, the stomach breaks it down, only about 10% gets into your body, and it doesn't work. Well, the FDA finally looked at all the studies and said, you know what? They voted 16-0 saying, you know what, this doesn't work. So everyone says, well, what difference does that make? It's in over 250 different medications. And now that the FDA has said that, are they going to make them pull all those medications? Are they going to make them remove that from the formulation? So you're talking Advil, cold and sinus, Sudafed, PSE,
Dayquil,
NyQuil, Dayquil, absolutely.
Okay, but here's my question for you, because I could line people up from here to St. Louis and back who say, well, no, I take them and it does make a difference. What are they experiencing?
Okay, here's the big thing. We used to call these, and I use the word garbage, and not in a derogatory term, but that's where you just throw everything, right? So you have to remember, a lot of these cold medicines have expectorants, they have antihistamines, they have fever reduction, they have cough suppressants. So whatever one symptom you have, that medication is probably going to help. So a lot of people look at it and say, you know what, all I want is my cough to loosen up. Well, if they just took guaifenesin, it was an expectorant that we know works, they'd get that. But instead, they're taking this multi-medication that has all these things in it. So it's a competition for the drug companies to say, put every medication you can in one pill, and we'll sell it as if it's a cure-all.
But my concern is they're so branded that even if the cleanup is done and we move forward with, no, you don't need all of that, you just need this, teaching the public to rebuy that, to me, maybe you're better off just letting them buy what they're buying.
Impossible. Exactly. What they're going to have to do is they're going to have to tell all these people, hey, what you need to do is take phenylephrine out and stop saying it's a decongestant.
But still package it with the same name.
They still will. They'll still package it. Look at
Sudafed.
Sudafed.
Yeah. But what do we look for?
Everyone thinks they're buying Sudafed, and they're not. They're getting phenylephrine.
So if we know phenylephrine, because I like to pick, if I have the stuffy face, I get Sudafed. If I have I need to dry up, I get something else. Or if I need the expectorant, I get that. If you are looking to unstuff, and we know phenylephrine doesn't work, what do we look for?
Well, it does work in the nasal spray. That's the distinction here, and I think that's even more confusing.
It does. It works in a nasal spray because it does exactly what it's supposed to do. It just doesn't get absorbed through the stomach well. But an actual person who really needs that decongestant, one, make sure you don't have high blood pressure because it'll raise it a little bit. But also, you can still get Sudafed. You just have to take that extra step to go to the pharmacist and say, I would like Sudafed. And they say, okay, give me your name, address, and all that, because they want to track to make sure that no one's going to go in and buy cases of Sudafed off. They used to have kids going in as runners and buying all these packages and then changing with a simple chemical thing, changing it to methamphetamine.
Blood pressure.
Real Sudafed still works. Got it.
Yeah, blood pressure myths and facts. And is your smartwatch really all that smart? We'll take that up with Dr. Most next time. We know you got to run to a meeting. I'm going to put you on hold for a second to talk to Tom, but thanks for being on.
So much
You got it.
stuff.
Thanks, you guys.
There you go, Dr. Most. We never have enough time.
I love him.
Never enough time with Dr. Most.
So good. But really, it's just all stuff you need to know.
I think what makes it awkward for the staff, and I apologize to all of you, but particularly Jane, because she's in the immediate room with me, is whenever I'm with a doctor, I take my pants off. So whenever I talk to Dr. Most, I remove my pants right before we talk.
I'm telling you, it's the weirdest thing. I try to give him a gown to put on. He refuses. Yeah. I mean, he's just on the phone with the guy.
Well, I've known Dr. Most for a long time.
It's real weird.
Yeah. So I'm sorry, Jane. I didn't mean
But
to make it comfortable.
the underwear you have on today are really cute.
Yeah, thanks.
Yeah.
I made them with my loom. Yeah.
Wow.
What's happening?
Didn't know he was that crafty.